I'm going to take this opportunity to really introduce the next session, which actually I asked for. This is for the young ophthalmologists, the next generation. As most of you know, that I'm really very interested in, and our future is very bright, especially whenever I come to India and I see there's so much interest by the next generation of young ophthalmologists. We call them YOs. American Academy of Ophthalmology calls them YOs, and ARVO and everybody else. So, and here it's it's really my honor and privilege that we have some of very bright young ophthalmologists who were trained at National Eye Institute. And this session will be chaired by Dr. Shailaja Chibriwal. I'm very proud to be, working with her, and she's just done an amazing job. And future for India and the rest of the world is very, very bright. So thank you, and I invite Dr. Shailaja.
Praise too much, Dr. Gyan Prakash. Thank you so much for that introduction and for the opportunity. So I would like to invite all our co-chairpersons. So Dr. Fulia would be connected online. She's a co-chairman. Dr. Nikhil is not here today, so Dr. Ria Ratna would be taking her place. And Dr. Akshay is a convener. So Dr. Naina Podar, please welcome as a moderator. So without much delay. Without much. So most of the speakers here are actually young ophthalmologists. I would say young ophthalmologists is kind of young ophthalmologist is kind of a misnomer. Young is from the mind, not from the age. I think most of the senior people here are more younger than what we think about. Their energy is really difficult to match.
Our next speaker is Dr. Shailaja Chibriwal, who's with the Shroff Charity Eye Hospital since 2013. She's trained in pediatric ophthalmology, strabismus, and neuro-ophthalmology at LVPI, and has been the recipient of multiple grants and awards, including the NEI-sponsored short-term training in genetics. She's also been the recipient of the USAID grant and the Eye Researcher Fellowship Travel Grant by the ARVO for conducting pediatric eye screening camps in the urban slums of Delhi. And she'll be talking to us on the genetic implications of common and uncommon pediatric eye disorders.
Thank you, Akshay. So thank you for the organizers for giving me this opportunity. I have no financial disclosure, and one more disclosure, I'm not a geneticist. I'm just a pediatric ophthalmologist with some interest in rare eye disorders. And my interest began because, when I'm in the clinic and I think about it, and more than 50% of the patients that I see have some direct or indirect implication, genetic implication to them. And most of the childhood blindness, if you see, more than 50%, in fact, almost 70% of the childhood blindness is caused by inheritable or genetic eye disorders. This leads to a huge economic and social impact because it adds to the blindness years and the productivity of the child throughout his life. As we have seen across this conference, I will not go into the details, but genetic eye disorders involve each and every part of the globe, and there are also systemic associations. So I'll just go through some of the cases. Each of these cases taught me and how genetics helped. That is how I would take the presentation forward. So this 26-year-old male, he presented with sudden onset, painless, gradual, progressive, simultaneous bilateral loss of vision. So basically, one eye was first involved, and within a few days, the other eye has been involved, and there was a painless loss of vision. This happened at 18 years of age. He presented to us at 26 years of age, and old documents showed that it was diagnosed as bilateral optic neuritis. He received IVMP for that at that time, but MRI was normal. So it is not unknown for optic neuritis to have a MRI negative picture, but this was something which was slightly different for this case. Current vision was 1/60 in both the eyes, which is again rare for an optic neuritis to not recover. And fundus showed bilateral optic atrophy. He also told that the vision loss kept on increasing over the years. So what was atypical is absence of pain, slow progression over the years. So I thought, am I missing something here? So just we went into the family history. And we found that there's one more person in the family who's also a male and related to him through the maternal side, who's also had similar thing like presented and diagnosed as optic neuritis. Now, it's very rare for an optic neuritis to be familial. So overall, there were 3 family members, in fact, who were affected, all diagnosed with bilateral optic neuritis at a young age. All are male members. Optic neuritis is more common in females. So all shared the maternal lineage. So there was a genetic connection here. So we are thinking about whether it's hereditary optic atrophy, which is here. So either LH1 or looking at the pedigree, it could be X-linked optic atrophy. Now in LH1, it is a mitochondrial disease, and in these both males and females are affected. But there could be a preference of the male, to be, to show this disease more often, and the female may not show it. And all this can be explained by a phenomenon called mitochondrial heteroplasmy. I'll not go into details of that, but this clinched us to, go ahead with a genetic testing, and we tested for the mitochondrial genes, and he got the 1178778 mutation, which is common mutation for the LH1. So what did actually provide for them is a sense of closure. They understood what the disease is, and it also helped us in counsel them further. So why was it important to make a diagnosis, a correct diagnosis? Because the prognosis is different in the 2 disorders, the management is different in 2 disorders. Of course, he was diagnosed too late for us to actually give any treatment for LH1, which is mostly effective in the first 1 or 2 years of the onset of the disease. So that opportunity was also lost in this patient because of a wrong diagnosis. And ultimately, it has implication genetic counseling, which can be beneficial in him because his sisters can be the ones who will be propagating them to the next progeny or the next generation. So genotype and phenotype correlations is another thing which is important in genetic disorders. I think this thing was covered in yesterday's talk that, LCA is caused by more than 70-80 genes and mutations. And all these different genes will have different kind of pictures in the eye. So some of them are associated with stable disease, some of them are associated with progression. So knowing the gene and correlating with the phenotype is very important for prognostication and telling the patients what to expect with time. So moving on to the second case, this is a 3-year-old case of a child with nystagmus since birth, sudden onset cataract since 3 months, and on examination found out to have aniridia. Now aniridia, we all know, is a relatively more common disorder, and it can be familial or sporadic. More commonly it is familial, 2/3 of the cases, where it is autosomal dominant, with PAX6 mutations being the most common type of gene which is involved. The sporadic ones are actually due to deletions of the 11p13 arm. And here, because of its contingency with the WT1 gene, which is the Wilms tumor gene, there is high chances of involvement of the Wilms tumor gene and causing of Wilms tumor, which could be around 50%. And that is 1 in 2 child may have, with a sporadic aniridia, may have a chance of deletion of the WT1 and have a Wilms tumor. So what did I miss here? So this child came to me, and do I go ahead and just tell them, no, you have a chance of Wilms tumor? No. Again, taking a family history. So this child actually had a familial aniridia, and we examined the parents. The mother had aniridia. There's another family member who was, so there are 3-4 family members who are having aniridia. So this is definitely a familial aniridia, and the chances of Wilms tumor are very, very low. So here it is kind of a negative counseling. You don't tell them that you don't need a Wilms tumor screening. Otherwise, those who have sporadic aniridia or those who are known to have WT1 mutation, a screening for Wilms tumor is advised till 5 years of age. So family history and examination of parents is extremely important in a pediatric eye clinic. It can clinch the diagnosis. It can give you specific phenotypes, like, if you see a female, if you have a male child with retinitis pigmentosa like pictures, you examine the mother and you can see the steatoretinal sheen in the mother, and it can give you a diagnosis of a X-linked RP in that child. Similarly, sutural cataracts in a child who is having cataracts can clinch toward either Nance-Horan syndrome or cerebrotendinous xanthomatosis. Now moving on to the third case. Now this case teaches us to look beyond the eye. So this is a 6-year-old male firstborn visitors in July with complaint of reduced distant vision, and diagnosis was of a mild lens subluxation. Along with that, he has a myopic astigmatism. So this was a kind of lens subluxation which was seen. If you look at the child, whenever we think of lens subluxation, Marfan syndrome comes into our mind. Okay, so we try to look, at least this is something which is not missed in my clinic, and everybody tries to look for Marfan's features, but not every time you get that classical Marfan's features. So this child did not have any wrist sign, did not have any thumb sign, no pes planus, no scoliosis, nothing. Only increased arm span to height ratio which was there, which was present. And another thing which was, he had a flatter cave, which was their keratometry. Other than that, nothing more significant. But there was a family history. When we examined the mother also had history of lens subluxation, and she was also tall and lean for age. But other than that, both of them had never been evaluated for Marfan syndrome. So we were also on the dilemma whether it is a familial simple ectopia lentis or Marfan syndrome. And as I've mentioned before, there are implications of a correct diagnosis. You need to know whether it's Marfan syndrome, because they are susceptible to systemic problems, especially the heart ones. So what we did is that we referred the child to a cardiologist, and to our, kind of expected that we saw aortic root dilatation and tricuspid valve regurgitation in this patient with a Z score of 3.62, which is a diagnostic criteria for Marfan syndrome. So here we had ectopia lentis, increased arm span, which is a minor criteria, aortic root dilatation, and family history, and that is how Marfan syndrome was diagnosed in this child. And he was then appropriately counseled for the recurrence risk, and the mother was also advised for a cardiologist opinion. He was also explained about to avoid rough sports, LASIK surgery, and agent stimulating the cardiovascular system. So systemic implications are also important when you are managing these patients, like patients with Hallermann-Streiff syndrome or Robinstein-Tybee syndrome. They could have systemic implications, especially when you are giving anesthesia for management. So this syndrome is associated with congenital glaucoma, and it is also known as broad thumb hallux syndrome. And the children have short stature and learning disabilities. So they have susceptibility to succinylcholine. So anesthesia may be dangerous. Sometimes you are the one who have to educate your anesthetist to actually take care of these patients accordingly. So if you have a diagnosis of Robinstein-Tybee on the file, even the anesthetist will look carefully at that child. So it is very important to have a systemic diagnosis. This one case, another taught me a lot. So this patient was referred to us for congenital cataract. Child had a cataract since birth and nystagmus. Also had this supination problem in the right arm, and had a heart defect, atrial septal defect, which was repaired a few months back before to our presentation. So the cardiologist had made a diagnosis of Holt-Oram syndrome, which is known to have a heart defect and skeletal dysplasia. So we also thought, oh, it's a Holt-Oram syndrome, but I had never known that Holt-Oram syndrome could have a congenital cataract or anterior segment dysgenesis along with it. So I thought, oh, it's a very different thing. Holt-Oram syndrome with this. Is there another genetic syndrome that I'm thinking about? So there was no previous association. So we went ahead for genetic testing. For Holt-Oram, I think it's a TBX4 gene which is involved, never known to affect the eye. But we got a BCOR gene mutation. And this is what Dr. Ann also mentioned in her talk. And this was like a reverse diagnosis. I was never thinking about BCOR because it was not in my brain. I never knew, or I never thought about this entity. So you look with your eyes, but you see with your brain. So you will diagnose only what you know. So after that, I mean, I'm trying to explore the different angle to it. In BCOR, very rarely 1 or 2 case reports of skeletal dysplasias is also present. So, but anterior segment dysgenesis have not been reported. So this is kind of a new finding in this patient. So last, people ask why to and when to order genetic testing. So sometimes it is to establish a genetic diagnosis where your clinical features are not fitting or may not be required in all cases. If your clinical diagnosis is conclusive, you may not require a genetic diagnosis. But to establish genotype-phenotype correlation and prognostication whenever it is affecting the disease, your genotype, and to estimate the risk to siblings and offsprings, it is a very important role in preconceptional counseling and prenatal testing. Just not go to this case. I think this is Ria will cover in her case where our testing helped in prenatal testing, and subsequently mothers was helped in a case of LCA. And there are so many other treatment options which are coming up based on the results of the genetic work which is done. So not necessarily every time it has to be a gene replacement therapy, but sometimes you may have to replace the defective protein, sometimes just the substrate to prevent the accumulation of the harmful product, and sometimes the process of genetic mutation may just be halted by using some drugs. So it has a lot of avenues, although all of them are not very applicable for all the diseases. Sometimes we are stuck that there is no treatment available, but I always believe that there is hope. And apart from all of this, we need to give supportive care to the patients, at least give them the option of genetic counseling, link them to the various other patients in the various patient forums, and of course, visual rehabilitation and cosmetic rehabilitation wherever there is no cure. Thank you so much for your patient listening.
Yeah, thank you, Dr. Shailaja. I think that was a fantastic presentation that's clubbing the bridge between the clinic and the laboratory from the phenotype to the genotype. Sure.
Okay, thank you very much, Dr. Shailaja. Excellent presentation. I have a broad question. So what percent of eye clinics in India are actually doing genetic counseling? And I'm going to pose this question to Dr. Kumar Manikabal if he's online. I'm just wondering if Dr. Kumar is online. Is he? Well, he'll be probably or anyone else can actually participate in this discussion. Okay, I'm going to let Dr. Shailaja try that first.
I think the audience, somebody's.
Okay.
Please give a mic.
Well, you can let them come here. That's
Please
fine.
come.
Please come on over here. Do you have an answer?
Yeah, so I'm aware of the fact that most of the eye institutes which are there do have the services of genetic counseling, but that would be like 5 or 6 institutes all across India. Apart from that, people who are a little bit aware of these conditions do refer to genetic counselors, but I think we did a small survey for our own. Ria did it across SCH network we did, and it was less than 10% who were actually referring for a genetic counseling or testing.
Less than 10%.
That was there.
Okay, thank you, ma'am.
Yeah.
Good morning,
Please
everyone.
announce your name first, and so that our international audience can actually watch.
We'll do that. So I'm Dr. Anuprita Ghosh, and I am presenting today in the afternoon session. So apologies if this is going to be redundant,
Okay,
but I am a scientist at GROW Research Lab at Narayana Nethralaya, Bangalore.
very good.
GROW stands for Genes Repair Regeneration Ophthalmic Workstation. And over these 6-8 years with Dr. Kumar's initiative, of course, what we have done is we have created a Gen Eye clinic, which is truly genetic counseling, which has a big, more than 50% component is psychology in that, psychosocial component in that. And I have personally visited to US for observerships. And so I was, lucky that way, and I was able to grow this program, what we call as Gen Eye Clinic. And I will be sharing data in the afternoon from there, including the psychosocial impact on the patients that we see. Yeah.
Very nice. Thank you, ma'am.
How many
What percent of?
Yes, so that is
It's very less. And what is
a little bit SN has been doing.
And there is a difference between how genetic counseling is, done in UK or in the US, where there is psychosocial component. Whereas when we talk about it in India, it is still at nascent stage. We are still talking only about, oh, this is the patient with genetic disorder and this is your mutation.
Yes.
But genetic counseling in a tertiary center like ours, where we club the scientific data as well as in the counseling, it goes beyond that. So I will be sharing that in the afternoon.
Very
Thank
good.
you.
We look forward to that. Let's see, Doctor. Okay, Dr. Brijesh, please.
Oh, my question is,
Where are you, Dr. Brijesh?
I'm in railway hospitals.
Here in Mumbai.
Jagjivan, Mumbai.
Okay, very good.
Jagjivan
Thank you. Thank you for
hospitals.
joining.
Basically, congratulations and thanks for your such kind of the prenatal. Basically, we need prenatal diagnosis. Then what is the parameter of this sampling and other things? And how to collect your sample, and from where, which center collect your sample of the prenatal?
Okay, so before you go to the question, let me just get the international audience for the previous question that
Yes.
I posed. So, Dr. Calvin Pang, I'm assuming you're still online, and Dr. Takeshi Iwata, would you like to respond to that? What percent of eye clinics are doing genetic counseling in China or maybe Hong Kong region, and then in Japan? And Dr. Iwata, would you like to make a comment? Can you put Dr. Iwata? Is he there? Yeah. All right,
Hi.
Dr. Iwata's question is that what % of eye clinics in Japan are currently doing genetic counseling?
So for the Japan Eye Genetics Consortium, we have 30 universities, ophthalmology department joining this consortium. Most of the clinics do not have a counseling because of the lack of the counselors actually. Can you hear me?
So
Yeah.
do you have any idea what % of currently doing?
Percentage will be less than 10%, I think.
So should we consider this the same stage as in India at this point? Should we consider this the same stage as in India, as it is in India?
Well, for the counseling, and also for the genetic testing, you need an expert panel to say that this mutation is actually involved with this person's disease. And that is a member of like 7 or 8 people requires. And some of the molecular biologists have to be there. Some of the specialists of political things have to be there. So there as a team, requires a number of people needs to be there. So that is a little bit stressful for many of the ophthalmology departments to have that group in there. And that's why it's less than 10%, I think.
Okay, thank you, Dr. Takeshi. He's based in Tokyo, as you know. So I would like to ask Professor Calvin Pang in Hong Kong if he's still online, and after that, if possible, if Professor Anne Slavotnik is online from USA. If you could please comment, and so that we can get a global understanding within the concept of GEGC, what is happening around the world. Professor Calvin Pang, please. You have Calvin Pang? Professor Calvin Pang, are you there?
Professor Anne is there.
Okay, let me then go to US, to Cincinnati. Professor Slavotnik, please.
Yeah, good question. I think in most academic centers, the major hospital has genetic counseling, but there are a lot of ophthalmology clinics, in health organizations that are not part of major centers that do not. So I don't think India is so far behind. I can't estimate a percentage, but we need it more. And I think that's the point you're making.
I think we do more we're doing more, but I have a feeling that we maybe just about maybe 20-25% in the US. Am I close?
Yeah, I mean, I think that's a reasonable guess. Yes.
Yeah. Okay. Very good.
Yeah.
Very good.
Thank you.
Okay. Thanks a lot. Do we have Professor Calvin Pang to give us an idea, or anyone else? Actually, anyone else would like to actually speak from outside India? I'm not sure if Dr. Hafnagel, Rob Hafnagel, is still online. It's past midnight of course, in Washington, D.C. Okay.
Hi,
Anyone else? Yeah, Ria, please. Miss Ria.
This is Dr. Shripriya from Shankar Netralia.
Okay, ma'am. Yes, thank you.
In Shankar Netralia, we have an exclusive genetics counseling unit where we work in coordination with the clinician. So the clinician refers the patient wherever they suspect genetic testing will be helpful for them. And also, when there is a family history, they are referred to our clinic where we do a proper pre-counseling and then get their consent for the genetic testing. And then we also have a post-test counseling to discuss with the patient about the test results. And then in coordination with the clinician, we help them. And in certain cases, as the doctor said, we also helped in prenatal diagnosis also, especially in cases with retinoblastoma. So we do have it, but as seen, we have only few centers offering genetic counseling in India.
Yeah.
Good. Thank you. So actually, let me make a recommendation here to Dr. Takeshi Iwata, who is the president of Global Eye Genetics Consortium. Please consider, if possible, if we can make it as one of the objectives of Global Eye Genetics Consortium to expand genetic counseling, and this would be more of advocacy and public policy, Dr. Iwata, if we can expand in the overall aims and goals of GEGC, if possible, and you can bring
Also, Yeah, but also this requires the government regulations.
Correct.
And
Correct.
Ministry of Health is involved. They make the regulation, they give this a status for these counselors. So it's probably different between countries.
But if we can create, Dr. Iwata, if we can create an opportunity within the GEGC, and several centers are doing it, Narayan Nethrala under the leadership of Dr. Kumar Manikavel is doing an amazing job. Shankar Nethrala, you just heard from Chennai, India, they're doing it. Many of you around the world are, so it's clearly it's in infancy. It's not, it needs to grow. And if you can actually please consider incorporating this in the goals of, my job, as you know, as a patron, as the founding president of Patron, is to give you strategic, vision. And this is something I've been kind of feeling the last few days here in India, in Delhi. And then I talked to a lot of government officials in Delhi at a very high level in the Ministry of Health, and people here, the leadership. And I kind of feel that I wanted to bring this to your attention, to the attention of GEGC leadership, to actually bring this to the GEGC Executive Committee and bring this and make this one of the objectives. So I'm going to stop here and turn to Dr. Shalja, who is the chair of this session. Thank you.
Thank you, Dr.
Thank you.
We'll move on to the next.
Yes, thank you, Dr. Shaileja and Dr. Gyan Prakash for the interesting talk and interesting suggestions. Now we welcome our next speaker, Dr. Fulia Tunke. Pardon me if I have pronounced it wrong, madam. She is the first participant in an ocular genetics fellowship program sponsored by the NEIN and the International Council of Ophthalmology. As she says, she takes home to her native Turkey hands-on experience, momentum, and a new network of collaborations. She has learned to prepare slides of zebrafish retina for imaging of blood vessels, a skill that she'll be using in her research. I welcome Dr. Fulia to speak on her topic, Approach to Genetic Eye Disease in Turkey. Welcome, madam.
Thank you. Can you hear me?
Yes, we can hear you, ma'am. Go
Okay.
ahead.
The video will play, or may I present online?
Yes, it is seen.
We'll play the video.
We'll play the video, ma'am.
Good morning. First, I would like to thank the organizing committee and my mentors for giving me this opportunity. Today, I would like to talk about the current condition of ophthalmic genetics in my country, Turkey. Turkey is a transcontinental country, as you see in the above map. It's surrounded by seas on three sides. It has a unique geographic position, including land both in Southeast Europe and in Western Asia. And throughout its history, it acts both as a barrier and a bridge between Europe and Asia. As you see in the below map, Turkey has 7 different geographic regions and 81 provinces. Ankara is in the center and capital of Turkey, and Istanbul is the most famous one. In Turkey, there are more than 85 million people. Half of them were women. The median age has increased since 2007. Turkey has an increasing elderly population. In terms of economical conditions, Turkey has an upper middle income economy, but the recent years, due to inflation rate, it has some economical problems, as somebody or some of you know. In terms of genetic eye diseases, unfortunately we had nearly no nationwide data. There are only single center studies. Also, they are low in number. I would like to mention about a recent single center study, which were conducted among children attending schools for the visually impaired. in Ankara. According to this study, the main causes of visual impairment reported as retinal dystrophies. And this study also showed a history of consanguinity was nearly 40% among the parents of those children. In general, in Turkey, the consanguinity rate was reported as 20%, and it could be as high as 40% in the southeast region of Turkey, which increases the rate of the especially autosomal recessive diseases and congenital birth defect rates. As many of us know, ophthalmic genetics is a subspecialty in ophthalmology, which combines the tools, increasing data and the technology of genetics in the genetic eye diseases in order to improve healthcare services for the patients and direct the research to increase the hope and possibilities for the patients. When we look to the current condition of ophthalmology practice in Turkey, there are nearly 3,000 ophthalmologists practicing in various clinical settings, including university foundation hospitals, training and research hospitals, and state hospitals, which were all public. And also there are private hospitals and private clinics in Turkey. There is no official ophthalmology subspecialty training in my country, but the Turkish Ophthalmological Association has sub-societies for retina, glaucoma, refractive and cataract surgery, oculoplastics, and etc. But there is no sub-society or group focused on ophthalmic genetics. In these conditions, patients with inherited eye diseases are evaluated firstly by the general ophthalmologist or the specialist in the cornea, glaucoma, according to the sign and symptom of the patient. And in an increasing rate, especially recently, they are referred to medical geneticists for genetic testing and genetic counseling. The handicap is here. The handicap here is that there are low number of medical geneticists in Turkey, and they are all responsible for all the genetic disorders. There is no genetic counselors in my country, and low vision rehabilitation centers are low in number in the current state. In order to understand the current condition and the needs among ophthalmologists in Turkey in terms of genetic eye diseases, we conducted a survey study. This survey study has 29 questions, and it asks about the occupational characteristics of the ophthalmologist, current practices and preferences in terms of genetic eye diseases, knowledge about available diagnostic and therapeutic options, and proposals to improve continuing education and healthcare services in the management process of genetic eye disorders. And we sent this survey nearly 3,000 ophthalmologists practicing in Turkey. Nearly 20% completed the survey. The mean professional experience years is 14, and nearly half of them were academic. Nearly again half of them were general ophthalmologists, and as you see in the chart, they are distributed in all the clinical settings, and also the respondents were distributed in all 7 geographical regions of the Turkey. When we ask the participants if there was a medical geneticist at their facility, 43% answered yes to this question, and the number is high in university hospitals and training research hospitals as expected. When we ask how many patients with genetic eye diseases did they saw in a week, and 76 of them said no patients, and most of the participants see 1 to 3 patients with genetic eye diseases in a week. And again, we asked to all participants if they had an active role in the management process of patients with genetic eye diseases, and 60% said yes to this question. And the following section of the survey included those participants who had an active role. And when we ask to those participants whom they take support from the other professionals during the management process. And the most preferred ones, medical geneticists, subspecialists, and specialists in low vision rehabilitation. When we asked to the participants who had an active role in the management process about if they question the inheritance pattern, if they comment genetic tests, or if they refer their patients for genetic counseling, you see the distribution of the answers among different clinical settings. There was statistically significant difference in responses about management strategies between subgroups. In university hospitals and training research hospitals, the answers of yes were more than the other clinical settings. When we asked the whole participants about their knowledge about genetic diagnostic tests, available genetic diagnostic tests in their facility, and which genetic diagnostic tests were covered by health insurance system, you see that majority of the respondents reported being uninformed about those things. And nearly 90% of ophthalmologists thought that training after residency in the field of inherited eye diseases was inadequate. And again, 94% of the ophthalmologists reported the need for subspecialty of ophthalmic genetics. There are opportunities in Turkey in terms of healthcare services. There is universal health coverage system, electronic health record system, the law on the protection of personal data, including genetic data, the Health Institute of Turkey, which was established in 2015, planning the Turkish Genome Project, and also there are increasing number of genetic testing centers, and the awareness among patients and physicians increases in terms of genetic testing in genetic eye diseases. And also there are low in number but increasing in number clinical trials and treatment opportunities for the genetic eye diseases. Actually, there is no genetic gene therapy testing, but there are other types of stem cell therapies, retinal prosthesis, some kind of trials, as you see here. But we still more to do to improve the condition. First of all, we need a national registry system for inherited eye diseases. We need dedicated centers, ocular genetic centers, to improve the healthcare services from one center. And also we need training. We could have fellowship programs, or at least we have training options for ophthalmologists organized by the Turkish Ophthalmological Association in terms of inherited eye diseases. We need standardized algorithms to help the physicians for appropriate and standardized management and referral system. And also we should encourage researchers, ophthalmologists, and funding agencies to increase the number of high quality research in this field. I would like to express my special thanks to my mentors and my supporting institutions during my journey in ophthalmic genetics. And thank you for listening to me.
Thank you, Fulya, for that excellent talk. We were just now talking about the same thing which you presented. Thank you for your amazing work. So it's heartening to know that in Turkey, there is a lot of awareness about genetic disorders, but I think you addressed mostly the university hospitals and the eye care facilities, these kind of hospitals, right? Not every clinic, yeah. So, yeah, Dr. Gyan Prakash wants to speak something.
Oh, hi, Fulya, thank you, and great to see you. I wish you were here, so we miss you here, but hopefully you'll be here soon. But most certainly, as you just heard the previous discussion we were having, how do we raise this issue? And I think I have a feeling that, you know, with your background, you just completed your fellowship at our place at National Eye Institute. And it was just a tremendous pleasure to have you, an honor. And, you know, Dr. Shalja comes from similar background. And so do you have any comment to the previous discussion question that, and we would like your participation in that, you know, making it a public policy, working with the government, although you don't have any genetic counseling in Turkey at this time, but certainly you could be part of the worldwide group that I'm trying to push at this point. Do you have any comment?
Yeah, Thank you very much for this opportunity. Actually, in Turkey, we feel the deficiency of the genetic counselor professionals because there are few number of medical geneticists in Turkey which are actually responsible for giving the genetic counseling, but they are responsible for all genetic disorders. So most of the genetic eye patients with genetic eye diseases could not get this service. Because there is no time, there is no place for them. There are long waiting lists. So actually, I think for all kind of genetic disorders, but actually for genetic eye diseases, we need that kind of professionals as genetic counselors and training systems. But as a political issue, according to the laws, the only people who can give genetic counseling in Turkey is the medical geneticists, is the medical doctors. So maybe there could be a change for this because it is not easy to increase the number of medical geneticists in the short term, but we could train, as in USA and as in other countries, train genetic counselors and increase their numbers to help the medical geneticists and to help people to get this service. So I'm actually supporting this kind of Global Eye Genetics Consortium aim. And I would like to make some kind of changes to talk with the governmental people to help about this. Thank you.
Thank you very much, Fulia. I'm going to turn it to Dr. Shailaja. Thank you.
Thank you.
Thank you so much. I think we are running a little bit behind schedule. So we'll just speeden everything up and kindly keep the timer on, and requesting everyone to stick to 10 minutes. Next is another dear friend of mine, Dr. Meenakshi Lalar. She was with me at the training at NEI. She is actually an obstetrician and gynecologist by her basic training. Then she did a DM in medical genetics from SGPGI. So this amalgamation of, genetics with clinical degree, and formerly she was with Gangaram Hospital, and now her expertise in reproductive genetics, prenatal diagnostics, and molecular genetics. So she would be speaking to us and enlightening us on how to do targeted gene testing for ocular disorders. So thank you, Meenakshi, for joining, and welcome.
Hi. So I hope my slides are visible, right?
Yes, they are visible.
Just a moment. I don't know what's it's running on its own. Just a moment. Yeah. So I'll have to take it like this. Yes. So a very good afternoon to everyone. I'll have to present in this mode. So my topic here is targeted genetic testing for ocular disorders, and I would be presenting it more from a clinical geneticist point of view here. So what is the first thing that we do? When we come across a patient, the first thing is that we ought to have a suspicion of a clinical disorders. There should be some genetic disorder that you are thinking of in mind. There is a suspicion that you have, either it's a syndromic or a non-syndromic thing. And we always convey that there should be some pre-test genetic counseling to it to help you choose the right genetic test. What is the yield of the genetic test should be discussed. The limitations of the genetic testing should be discussed with the patients, because it's a very complex and an economically and challenging process sometimes for the patients. So right phenotyping and right test choosing is very, very important in such a case. So I'll be presenting this by means of two cases. The first case is that was referred to me, a 6-month-old child with complaint of some eye anomaly. And the parents said that he has some weird looking eyes and developmental delay. He's lagging behind the peers. On examination, there was aniridia and there was ambiguous genitalia in the child and developmental delay as well. So we know that now we have a child with developmental delay, aniridia. I would always think of the PAX6 gene mutation here. But what we have to do here is we have to think of that, is it a large gene mutation here or it's a single event? like Dr. Shelja discussed in her case, we want to see if it's a point mutation, nonsense, a larger event, because that is going to help us choose the test. It's a chromosomal or a single gene. And if it's a large deletion, we have to choose a test looking like at the larger portion, a karyotype or a microarray. And if it's a smaller deletion point or a nonsense mutation in the sense, we have to do the panel testing or the single gene testing. A wrong test will not lead us anywhere in such a case. So because there was ambiguous genitalia, developmental delay, and aniridia, so look at the whole picture, we were thinking of a larger event and we got a deletion. This is how the microarray looks like. We've got a deletion at the chromosome 11p13 region, which involves the PAC6 and the WT1 gene, and that is the WAGR syndrome. And here we know that because the WT gene is involved as well, there is the utility of the genetic testing comes into picture. Not only did you make the diagnosis of the syndrome, but also you got the child into the surveillance for the Wilms tumor. That could be very important for the family in the long run for the late onset nephropathy as well. So that is how the genetic testing helped the family. Secondly, the reproductive risks. Is it going to happen to my child again? Is it because of something in my family? You know, all these things, the stigmas, all this, that is also taken care of during the post-test genetic counseling session. So the next case is that of a child with a high myopia. So this child came running around to various clinicians. The child has high myopia. That's not the main concern that they came to me with. That was that the child, a pediatrician thought that this child looks a bit different. He's been operated for cleft palate, has high myopia, and on genetic evaluation, I thought there is a motor delay in this child. Though the child has normal cognition, normal speech and everything, there is a little bit of abnormal gait. And the antenatal history, that's very important to take. Always just remember your MBBS days, your pre-med days, that you have to start history from before the birth. So just take into all those accounts. There was IUGR with abnormal Doppler and polyhydramnios. When I look at the child now, there is dysmorphism. There is a broad forehead, there is hypertelorism, there are bilateral epicanthal folds, there is the depressed tip of nose, low set ears, and see this mouth, it is such a small looking mouth, there is microretrognathia. And the eye findings, I'm not the expert in that, but they said there is high myopia, straightening of blood vessels, and somebody had also, an ophthalmologist had written that this is retinopathy of prematurity, and there was hearing loss. Clinically, not much, but objectively, she had bilateral moderate hearing loss. So now I have a child with high myopia, hearing loss, cleft palate, failure to thrive, dysmorphism, and skeletal changes. The first thing I thought was could it be 22q microdeletion, cleft palate, dysmorphism, but the echo was normal. And the second differential here was Stickler syndrome. And Stickler, we know through our training, it's a single gene disorder. So I am going to order here for the single gene testing. And rightly so, we got the mutation. It was a heterozygous, previously known mutation in the COL2A1 gene, known to cause Stickler syndrome type 1A. Now, how did we help the family by means of genetic testing? Now, I know this syndrome, the child is at a very high risk for retinal detachment. Through contact sports should be avoided. There should be annual physical and evaluations by the vitreoretinal specialist, by the ophthalmologist should be closely involved. And that is what I put them. I put them in close contact with the ophthalmologist because they just went once, and surveillance is very important in this case. Again, the reproductive counseling is important. The follow-up for the hearing and all is important. Skeletal is involvement. So so in this case, the orthopedician also needs to be involved. Now, the second thing to consider is there is a very common complaint from my colleagues in ophthalmology and other branches. What do we do if we get an inconclusive genetic report? How do we face the patients? It's so distressing because just think there could be some technical and scientific limitations. That is how the pre-test genetic counseling helps. You help the patient to help understand the report. It could be a wrong test that you've ordered. There could be wrong phenotyping. Just go and look at your patient again. And here, look at the patient from head to toe, not only the eye, look at the patient as a whole. Take history from antenatal. It could be a bit time consuming, but it would be helpful. Another case scenario, if there is an 18-month-old boy who comes with retinoblastoma, the catch here is with developmental delay and dysmorphic faces. Karyotype is normal. Family history is unremarkable, which is the appropriate test. I got some people to say that it could be the sequencing, but no, the microarray. Just again, look at the systemic picture. Developmental delay, dysmorphic faces. With training, it will come. If you will look at the patient from head to toe, it will come. And we can all do it, because we've been trained it. We're not doing it for a bit now, but we are all being doing it. It will come with the practice. Another thing is, what if you get some variant of uncertain significance in the report? This is another problem if you're sending for the single gene analysis. Just go and look at your patient again. This is what we clinical geneticists call the reverse phenotyping, a timely reanalysis. Tell the patient to come to you again after 6 months or years, do segregation studies in the parents, have a look at the population variant and databases. And if it is too much, we can always, take the help of a colleague in clinical geneticist or a molecular geneticist for this. It would help us. So I would end my talk by saying that what are the learning points? Accurate phenotyping is very, very must. Just look at the whole picture, not only ocular, but systemic. History, systemic examination is very important. Genetic referral is important. If you think that something does just not seem to fit in, because rare is rare, but in a country like India with lots of population, it would be common. You will find it so commonly in your routine practice, just if we keep everything open. And it is important, if we know the genetic basis of ocular disease, choosing the correct test, because it's costly. It's once in a lifetime kind of a test for many patients. And definitely you can take help of a molecular or a clinical geneticist or a lab. And pre and post test genetic counseling is vital to guide the patient that what is actually all is going around. It's to help the patient with the test results. And it's important to interpret the genetic reports in a correct way. Even after negative reports, do not lose hope. Looking at the patient again, looking at the reports again, maybe after a few years can help us again. And the last thing is, collaborations are very important between our societies. If there is a eye society and a genetic society in India, I think we all should collaborate. So we all can learn, and we all can ultimately help our patients. So thank you. I would like to end here.
Thank you, Meenakshi. I think I agree totally with your last sentence, and that is the root for having you today here amongst the speakers. So thank you for that excellent talk. And I would like to invite the next speaker, Dr. Nazmul Haq Kalol. Is he is there online?
Yes.
Yeah, Nazmul, hi. So again, one of my good friends, we were co-fellows in LVP. And after that, he has moved to do a lot of genetics, and he has done PhD in medical science and genetic analysis from Japan, doctoral in virology department from Japan. And currently he has gone to Detroit for postdoc researcher in pharmacology and eye department at the Wayne State University of Detroit. He's actually from Bangladesh and a very good friend. Thank you, Nazmul, for coming, and please go ahead with your talk.
Thank you. Thank you. Let me share my slides. Is it okay? Can you see it? Can you see it?
Yes, we can see your slides.
So I'm Nazmul, and I'm first, before presentation, I will thank the organizers for letting me talk and present here. And today I'm going to present one complex case that a genomic and molecular biological approach to find complex mutation in that case with a retinal disease, and it's a syndromic case. So actually what we see around us, everything is genetics. All conditions are genetics. I find most of them are genetics, except the traumatic cases. So genetic is very important. So this is IKBKG gene or NEMO gene I'm talking about today. So this is NEMO gene has 10 exons, and this pentagon shaped area, it is this triangular area, these are MAR repeats. I mean, in genetics, you will see that there are a lot of repeat repetitions in the genes and inside the genes and outside the exonic areas, and that's why it's very complicated to find mutations always. So here, this is the IKBKG gene, and the same area is in the reverse manner around 21.7 kilobase away, and that is to call delta Nemo. So whenever Nemo gene you are going to find mutations, so delta Nemo is also coming. So mutation analysis, I mean the primer designing is very complex, and in IKBKG Nemo gene, from exon 4 to 10 is deleted, and a complex disease occurs, and when this is major deletion, 11.7 kilobase deletion, so the Nemo gene becomes like this. This kind of deletion also is found in delta Nemo, and delta Nemo is like this. So Nemo protein is very important in inflammation, immune response, and prevent apoptosis. So and this is part of NF-kappa B pathway. So it is very important. And here, this is the mutation spectrums. This exon 4 to 10 deletion, it is about 80% mutations. I mean, about 80% is causing IP is exon 4 to 10 deletions, and other 20% is point mutations, and these are these red. I marked these at red here, and these are also, I mean, amorphic, large scale loss of protein, and you see, when there is missense mutations, I mean a little bit less devastating, I mean less symptom is there, and that is then the disease is caused EDA-ID mutations, and these are these black mutations, those are hypomorphic, and this EDA-ID has a less severe features in case of the disease other than IP. So here again I'm showing what are the primers used in case of Nemo. Here outside into, this is specific Nemo specific primer is used, and JF3R second to detect exon 4 to 10 deletion, and when there is deletion, only 3032 base pair band is there. And you see, in case of here, in case of IP disease, also intact cells are there, because there is mosaicism. So for intact cells into a Nemo exon 4 to 4 reverse primer is important, and in that case these primers 3358 base pair band is there. And also similarly, delta Nemo has to be tested by delta Nemo specific primers, and also intact cell like delta REF2 primer and Nemo exon 4 reverse primer. So this is not easy. I mean, you have to, for one mutation, you have to test 4 times to see whether there is a Nemo deletion, Nemo intact cells, delta Nemo deletion, and delta Nemo intact cells. So this kind of complex mutations, mutation analysis has to be done in every cases. So let's talk about some incontinent pigmented diseases. So this is usually lethal in utero in case of male, and the males are very rarely survives, and by karyotyping, Klinefelter syndrome, and somatic mosaicism. Females survive through skewed inactivation of X chromosome, and the differential diagnosis already I have shown that EDA-ID and causative gene is IKBKG or Nemo gene. So this is I mean this is X-linked dominant genodermatosis, so skin, teeth, and the hair, and the brain, nails, and also ocular involvement is there. So skin, there is different stages like blister-like vesicular stage, pustular, and hyperpigmented and hypopigmented stage. And these are already, I said, the cone shaping scissor teeth is there, coarse and lackluster of alopecia, and also pitted thick nails are there, and bilateral cerebral atrophy may be involved. And in ocular complications, about 35% of all IP patients have ocular involvement, and which often may be asymmetric, non-retinal and retinal. Now, in non-retinal, strabismus and cataract may be there. And in case of retinal, early stage avascularity and hemorrhage from the tortuous vessels is there. And later on, in the late stage, fibrous tissue and ultimately retinal detachment occurs. So in EDAID, which is a little bit less devastative, this is X-linked recessive and only males are affected, and increased susceptibility to bacterial and pneumococcal infections, and we can severe infections are there, and the mutations are a little bit hypomorphic and missense. So practically, I did 5 Japanese IP patients during my PhD period, and genomic analysis of 5 Japanese IP patients. Among them, one was a rare male case, and the others were female cases. So this is one boy case, and I did detailed genomic analysis, and the clinical manifestations. So skin findings were like IP, and ocular signs where retinopathy is there, and among the other abnormalities, teeth abnormalities are there. And these 3 patients, the mother has retinopathy involvement. So after the PCR, we saw that in the saliva of the boy showed an exon deletion, and the other, these red colors, these 3 females, and also one on mother of the female, they showed deletion of the exon 4 to 10 deletion. And then intact Nemo, as I said, we have to do 4 type of mutation analysis. So intact Nemo was found in all patients, in all cases. And interpretation is that, as you see, normal cells and mutant cells both were present. So boy's saliva tissue had mosaicism. Here, saliva has both deletion and also intact Nemo. So interpretation is boy's saliva tissue has mosaicism. So in delta Nemo exon 4 to 10 deletion cases, delta, there was no deletion in delta Nemo, and intact delta Nemo was there. So also we did mosaicism assay of saliva, and deletion is 45%, and mosaicism ratio is 45 to 55 in case of boy's saliva. And breakpoint analysis was done, and we found that the breakpoint is inside the MAR repeats, and for that this 3032 base pair PCR product of boy's saliva was used along with these 2 primers, and here we found that upstream of the MAR repeats, this upstream of the MAR repeats, and so was continuous with this downstream of the MAR repeats, and so we found that the breakpoint is here. And one important thing is that sometimes you will not find mutations, because extensive mutation analysis, after one of the girls, I could not found any mutation. And you see this kind of things happens because Aradha et al. Who did extensive research on IP, he also found, did 357 IP cases and 277, and that is 78% showed recurrent exon 4 to 10 deletion, remaining 80 cases did not show any mutation. So this kind of thing also happens, as I did not find mutation in one girl. After after extensive search in all exons around exonic area and also in the promoter area.
Dr. Nazmul, if you can summarize soon.
Yes, and so out of 3 girls, 3 out of 4 patients showed anemo exon 4 to 10 deletion, and one was de novo, and another girl was inherited. And boys' saliva DNA showed exon 4 to 10 deletion with 45% mosaicism. Since ocular tissue is ectodermal origin and which is similar to saliva, and eyes would have the mosaicism, so causing retinopathy, we can say that. And deletion breakpoint analysis was done to understand the disease progression, and also direct sequencing analysis was done to see the breakpoints of the deletion. Furthermore, it might be the clue to development of IP and IKBKG research works. Thank you.
Thank you, Dr. Nazmul.
Thank you.
Invite. We do have a dedicated time for Q&A a little later if you're able to take in questions at that time.
Is Dr. Srujana Adhikari there? I am, ma'am. Yeah. She is the head of the Department of Pediatric Ophthalmology and Strabismus, Tilganga Institute of Ophthalmology, Nepal. She has received a medical degree from Rajshahi University and has completed her MD from Tribhuvan University. And after that, fellowship in Pediatric Ophthalmology and Strabismus from Medical University of South Carolina. She has been practicing ophthalmology since last 17 years, and her areas of interest are pediatric eye disease, strabismus, and adult cataract surgeries. I welcome her to speak on the topic, the challenges in developing world setups. Over to you, madam.
Thank you, Dr. Sailaja and Dr. Joan for inviting me. It was nice meeting you last week in Delhi. Today, can I share my slide?
Yes, please. Yes, please go ahead, ma'am.
Okay, good afternoon, everyone from Nepal. I'm Dr. Srijana, and thank you, Dr. Sailaja, Dr. Joan, for inviting me for this talk. Actually, most of the things that have been already discussed, that challenges that we get in developing world setting for the genetics in ophthalmology, and we are in a very early stage of genetics in this world, in developing world, and in Nepal also we are just in a sensitization stage, actually, that genetics is there and we have to do something in that stage, and we still have a lot of things to do in genetics. And I have no financial disclosure or conflict of interest, and like we all know, it's a rapidly evolving field, the genetics, and then eye is the most frequently involved individual organ. So it is eye ophthalmology and the genetics are very much interrelated, and there is a very much great role of genetics in ophthalmic diseases, and almost half of the childhood visual impairment and blindness also has a genetic etiology. So, but still, genetics have evolved a lot. It has made a lot of progresses, but but still there are so many things that is yet to be done, like the disease treatment. It's still not evolved, and still in its very initial stage, the genetic treatments of the many genetic diseases and translation of the research findings of genetics in the public health application is also lacking, and the raised expectations that the genome can science still have a real impact in our life, it's still not unmet. So these are the things that are still going on in the genetic field worldwide, and a lot of things still is to be done in worldwide also. And especially that when we talk about the challenges in our setup, in our clinical setup, in our day-to-day practice with the interaction with the patients, what we find is that it is about even among the healthcare professionals that about the availability of the test, there is lack of awareness about the availability of the test, importance of the genetic test, applications of these tests on the daily clinical practice. Also attitude towards inherited eye diseases, like can't do anything to your child attitude. There is no treatment. It's in the research only, and it's available in the Western world only. So these are some of the lack of awareness that persist among the healthcare professionals. And among the patients, the test, they have the concept that the test reveals your genetic informations, the child suffering from very rare diseases, and it's impossible to treat. It's the disease of the rich and first world people. So how can my child be infected with, affected by this type of diseases? And it's very expensive and not worth doing all the tests. And decision making from the parents' side is also difficult, like fear of social stigma and personal relationships. So these are the lack of awareness among the parents and the patient's side in our setup, and lack of information from us, for us, like lack of accurate data on genetic conditions and inherited disorders. There's very few birth defect registries and less research priority on the inherited eye diseases. And another challenge is the lack of expertise, like trained ophthalmic genetic personnel, clinical genetic specialist, and genetic counselor, who has a very great role and most important role, I should say, because inefficient or improper counseling can have a huge impact on decision making on parent side. So the genetic counselor should be very well trained, and there is lack of genetic eye disease clinic, and genetic subspecialty is very least prioritized in any eye hospitals in developing countries. And of course, the most important thing is infrastructure. It's a very big challenge to set up a genetic lab, and to have a different tests of ophthalmic interest is also very difficult, and private hospitals and only private hospitals and clinics provide these things, and it's far from the government priority, because the government is still struggling with the tuberculosis and malaria diseases. And of course, there is another one important issue, is the ethical issues that comes with the genetic tests, like the families concerned about family planning, relationships with other family members, stigmatizations, and these are some of the ethical issues that come along with the genetic tests. And informed consent and gender issues in our part of the world is also an important thing. And another one most important thing is that availability of intervention for the results. So what next? The questions raised by the parents or the family members after we ask them to do the genetic test. What's next? What is the treatment? So that is one important questions that always raise in parents, and we have to face those questions. And another things, like I said, anxiety, fear of disease in the next generations, and also the asking the other family members to go through the test apart from the patient itself is also a challenge. And we have a very lack of strong ethical committee. There is lack of clear law and enforcement in this field, and consumer right issues are there. So these are the problems that are faced by the developing countries. And also one important thing is quality assurance. The unregulated commercial genetic testing services may create problems in the developing countries. So it should be very nicely supervised and by the skilled scientists. And also direct to consumer offer of genetic testing is posing ethical issues as well. So these are the and it's in the questions on the clinical utility, and misinterpretations of the result is also important to be supervised. So these are the challenges we have. And type of test, which test to order. Like there are so many different tests which have a difficult interpretation because of the genetic phenotypic and allelic heterogeneity, and availability of the test that is required by the clinician is also lacking, and cost of the test and time of the test is also important. And the policy, in the policy level, the challenges are to define the type of the genetic services that is needed according to the prevalence of genetic diseases, which we are lacking. So we, in the policy level, we have to make them, the policy makers, to convince them that we need genetic services, but that is also from our part is challenging to convince them. And development of and implementations of the services in the low cost in the primary healthcare setup is also important thing which the developing countries should follow, but it is a challenge. So it's not included in the government priority, as I said. And in Nepal, we have only one trained clinical genetic specialist, one dedicated clinical genetic lab, and which is very, very expensive. There is no ophthalmic genetic clinic or service in any hospital in Nepal, no ophthalmic genetic specialist, no genetic counselor is there. And there is lack of data, and only one ophthalmic data is there till now for the in which we did genetic analysis in congenital eye diseases in Nepal. So, so in conclusion, the genetic services should reach to the public and community level, actually, especially in the developing country setup with a low cost model, and should be incorporated in the daily clinical practice, and should be established as an important subspecialty service, and strong ethical committee and regulatory body should be established in developing world setups. Thank you so much. That is all my presentation.
Thank you, Srijana, for that excellent talk. And we can totally relate with all the challenges that you are facing. Similar is back at home. So we are all in the same boat. So, but with this conference and in future, we're trying to bridge those gaps. Because of the time restraints, we'll move on to the next talk. Ria is ready with her presentation. Go ahead, Ria.
Hi, everyone. I'm going to be talking about ocular genetics from a genetic counselor's perspective. And most of the things that I'll be pointing out have been mentioned in some or the other context throughout the talks. So I'll try to make my talk more unique by trying to talk about it in a eye-specific manner, and also very realistic, real-time scenarios that come up in the clinic and how we are able to tackle them. So I would like to emphasize that genetic counselors in any subspecialty, basically the role is never to give them advice about how to care for the eye per se. It goes beyond that. The management and the treatment's always the role of the ophthalmologist, and we try to focus, like Dr. Ghosh mentioned, on 70% of the role is psychosocial, and about 30% is about testing, counseling, and so on. And the two subspecialties, genetic counseling and ophthalmology, must go hand in hand and complement each other throughout. So just the textbook definition of what it includes, WHO defines genetic counseling as the process through which knowledge about the genetic aspects of illness is shared by trained professionals with those who are at increased risk or either having a heritable disorder or have a risk of passing it on to their unborn offsprings. So just going over the role, the first step incurs analyzing the family history and inheritance patterns that are present. So any patient that walks in, first step is pedigree charting, and try to find out whether it has occurred in the family. Sometimes the history that they give is not very direct. For example, especially in diseases where expressivity is different, and there might be very small signs of the disease. For example, a child with MAC, and we make it a common practice now to send the parents back to the ophthalmologist for screening, and there might be small signs of columboma in the parent. That changes everything for us. That gives us that gives us clues that if we do genetic testing for this specific family, we are likely to find responsible genes, and our counseling would change. We provide information about the genetic test. So it's not as straightforward as telling them, this is the disorder, this is the test required. There are a lot of pros and cons. There's pitfalls of testing as well. Some have been addressed yesterday, like variants of uncertain significance, how to deal with them, the economic burden that comes with genetic testing, the possibility that the first test will not give you the result and there might be additional testing required, and the fact that there might be parental testing required to prove your primary testing, and so on. So all these things need to be discussed in the pre-test session itself. And of course, families to understand the significance of genetic tests in relation to the personal and familial context. A lot of times, I'm seeing a primary patient, I educate them about the risk of other family members, for example, their siblings and children of their siblings being at risk. So it's important for me to tell them that, and then there can be aspects coming up like we are not in touch with them, we don't want to speak to them, we do not want to reveal our genetic diagnosis to them, and how to deal with those scenarios, how to make them look at the importance of speaking to them, or if they are not willing to speak to them, they can refer them to us and we can speak to them as a separate unit without your presence, and so on. And of course, provide referrals to education services. This comes in special context to eye, because with limited vision in some children, it's very important that they're receiving the right kind of education. A lot of times parents are very apprehensive to send their kids to blind school because of the societal stigma attached to it. And then kids start to lag behind in normal schools and there is complete denial of those facts. So it's very important to make them see beyond that, that your child will do much better, what kind of services a blind school would be able to provide to them. And information about going to other healthcare professionals if that's required. This especially comes important in multisystemic disorders. So if we have lens subluxation, we always send the patient to a cardiologist as well. So what are the cases where genetic testing comes important? One is, of course, diagnosis. And this comes in context of sometimes we have seen very often in the clinic that in the eye setup also, that we will not do the test because the common perception is there's no treatment. Why should we do a genetic test? But that's where counseling comes in, because you sit with the patient and you understand why. I have had cases where patients want to get genetic testing done simply because they want an answer, simply because they want to know what gene is involved and what is causing the disorder, because maybe they want to go back, they want to look on the internet, read more about it, see what kind of work is happening around the world, and follow up at a personal level about the disease. So genetic testing is valid only for diagnosis as well in those cases. Management and treatment advice changes. I'll follow up this up with examples from cases. Extended family member screening, prenatal testing, which is when it's most commonly used in this scenario, and predictive testing. So when is genetic testing needed further? Just going over some points, that genetic counseling is desired and reasonable. Sometimes patients would want to get genetic testing because it's a balance between anxiety and relief. If a disorder is late onset, you have it, you already have children, and they will only develop, they're young right now, they're 5-6 years old, they will only develop signs by 13, 14 years of age, 15 years of age, and so on. A lot of things need to be discussed about patient autonomy, minors' rights, and who can take decisions, what it means for them to be taken. So just doing the genetic test because the parents want it, what are they expecting out of those results? How do they think it will change the future of their child who does not have symptoms? So all these things need to be managed. Again, in the last few presentations, it has been stressed that isolated aniridia and Varger. So the difference, whether we should only be doing Wilms tumor screening till 7 to 8 years of age, or do a genetic testing and rule it out or in once and for all. That's something to discuss. And of course, in the multi-systemic context. So I'll take a few case examples as much as time allows and discuss about the genetic counseling aspect. I had this family where the proband came to me, the 24-year-old with aniridia. The family history indicated that she had a sister, mother, and a half brother who were similarly affected. She was 24, recently married, and her objective was preconceptional counseling. Because we know aniridia is mostly caused by PAX6, we ordered a sequencing analysis for her, and we did get a mutation. Only difference was it was a variant of uncertain significance. So what does my role come in here? I look about the mutation. I see what all literature exists and what is the context of this mutation with the disease as of now. And there were some mixed reports. Some were reporting it as benign and others were reporting it as pathogenic. But more or less, a lot of them have reported that it has a deleterious effect. I said, okay, what else can I do for the family? So her objective was preconceptional counseling. And since there are several affected and unaffected members in the family, I went one step ahead and I tested her affected sister and an unaffected uncle. Her mother was unavailable. Okay. So I could find through segregation analysis by testing unaffected and affected members that this specific mutation is pathogenic for the family. And we also wrote a paper and reported the variation because, again, if we ever find, and we will always find VUS, and if we can find pathogenicity, we should always report it so that others can then establish their significance accordingly. So I'll now skim over my cases. This is a case of Marfan syndrome. The only unique thing here was the patient came to me with a diagnosis, but so it was important to establish what are they looking in it from my side. They just wanted to be 100% sure what to expect in the future. So it was my responsibility to see whether there can be other fibrinopathies, anything else with connective tissue disorders that might change the diagnosis, and hence the management advice was given. Okay, I'm going to skip over the next two cases and just focus on the take-homes from here. That it's the genetic counseling and ophthalmology, it does become complicated. A lot of retinal disorders specifically, a lot of developmental disorders are polygenic, and what tests to order, how many tests are required. Pre-test counseling should include a lot of discussion about the fact that some syndromic reports can come, incidental findings can be present. Sometimes you will do all the tests that are present under the sky and you will not get a result. Post-test counseling is important to explain about VUSs, and cross-referrals are very, very important. We need to work with other specialists as well. The discussion about prenatal, preconceptional context. So oftentimes, I think someone pointed out that the way genetic counseling is carried out in Western world versus India is very different, is because it's very, very systematic in the UK and US. There's a telephonic call that happens much before the patient. We have a lot of history and what the patient is looking at even before the patients entered the clinic. Here, it's not the same. Here, referrals are made and patients are walking in all the time. So a lot need to be discussed, and patients don't always come back. Follow-up is poor. So a lot needs to be discussed in the first and second session. A bond needs to be formed between the family, and all the important messages need to go across. So with that, I'll take a leave. Thank you.
Thank you, Ria. And if people have questions for her, maybe we can.
Can I make a comment? I'm so sorry. You're late, but I know. But I want to challenge the international audience, right? So, so thank you, Ria, for. I mean, I know your talk is always. I've known about your work. Dr. Umang and I talk about your work, and Dr. Shalja and I have talked about your work. So, thank you so much for your. And there are places like Shroff, Arvind. Shankar Nethralaya, Narayan Nethralaya, Aditya Jyoti, you are all pioneers. You are all what you're doing. But again, I want to challenge the international community here. People who are people like Dr. Takeshi Iwata, Calvin Pang, Kumar Manikaval, and so on. And my colleagues from the US who are, if he's still awake, there is past midnight in the US. I know that in Japan is comfortable, but Dr. Iwata, just a challenging question to you. Do you think that we have enough information and data to really are people who would be willing to support if we were to reach out to top journals? Dr. Shalja and I, while I'm sitting in the back here, we've been communicating on text actually. So is this the right time to actually communicate to the top journals to make this and say that this is going to be a GEGC, one of the specific goals? So I'm going to challenge You don't need to respond to me right now, but this is just a question to the GEG executives.
But I was a little bit thinking after you raised this question is that there is a international or a local council society for each of the countries. Like Japan will have like two, I think there is two genetic counselor society, and they make up all the rules for each of the countries. So I'm sure there is a Indian genetic counseling society. I don't know.
Is there one?
There is one. It's very, it's relatively new and it's in the nascent stage. And we are now in talks with governments in the US and UK so that our qualification and board certification can be recognized around. So US right now has the most acceptable genetic counseling course, even within Australia and in Europe. If you move countries, you have to do the qualification. So there's not a lot of synergy, I would say, in the qualifications right now, but that's the overall goal. India is moving towards that. Yeah.
That's great, actually, what you just told me. So, Dr. Iwata, my question to you, would you consider, or should we consider bringing that community on with the GEGC, working with GEGC, and making them part of it?
Yeah, right? If it's required by the members, yes, of course.
Wonderful. Thank you. Thank you.
Thank you, Dr. Gyan Prakash. And move on to the next talk by Dr. Deepika C. Parmeswarappa. She's a consultant at LV Prasad Eye Institute, and she completed MBBS from Hassan Institute of Medical Sciences and Research Center in Karnataka, and post-graduation from Prabha Eye Clinic and Research Center, Bangalore. And then she did long-term fellowship in retina and vitreous from LVP. And she has presented lots of papers and posters at various conferences, and areas of interest include inherited retinal diseases, diabetic retinopathy, and imaging modalities of macula. So Deepika has a recorded talk, kindly play, and she's also available for questions. She has Deepika, can you share online?
Yes,
possible?
I'll just give me a minute. Yeah.
Can you share? Yeah, we've got your slides. Yeah.
A very good afternoon to all. At the outset, I would like to thank GEGC platform for providing me this opportunity. I am Deepika. I'll be presenting on evolution of circle gene related autosomal recessive retinitis pigmentosa in a single family. These are the abbreviations which I'll be using in the subsequent slides. CRKL, ceramide kinase-like protein, RP, retinitis pigmentosa, standard vision-related abbreviations, fundus autofluorescence, optical coherence tomography, and full-field electroretinogram. The objectives of my talk today will be to understand the various phenotypical presentations at different ages in circle gene associated RP patients in a single family, to differentiate circle gene associated RP phenotype from other typical RP phenotype. RP is the most complex IRD with respect to genetic heterogeneity and numerous clinical variations in the phenotype. There are more than 200 causative genes identified for IRD and about 90 causative genes for RP so far. My first case, the proband is a 10-year-old boy with a history of reduced central vision from the age of 6 years. On further evaluation, he did not have any peripheral vision problems or night vision problems. His best corrected visual acuity at presentation was 20/80 N10 in both eyes with compound myopic astigmatism. Anterior segment examination was unremarkable. The fundus of both eyes showed minimal arteriolar attenuation. central macular atrophic changes. There was neither remarkable pallor of optic disc nor pigmentary bony spicules or chorioretinal atrophic changes in the retina. The fundus autofluorescence of both eyes showed hyper-autofluorescence ring around the fovea with hypo-autofluorescence inside the ring and a central sharp speckled hyper-autofluorescence. The OCT macula of the left eye showed loss of central photoreceptor loss, which was quite diffuse, covering the entire length of the scan. Apology for the poor quality of the scan. Right eye also had a similar picture. The ERG recorded by standard ICF guidelines with skin electrodes by LKC technology showed near extinguished isolated rod responses, reduced amplitudes of A and B wave in combined rod cone responses, and photopic ERG was near extinguished, indicating severe affection of cones over here. That is the interesting point of this phenotype of circle. A detailed 5-generation pedigree chart revealed 6 members affected with similar complaints. Almost equal affection of males and females is seen, hinting towards an autosomal recessive pattern. There was no history of consanguineous marriage in 5 generations as per history at least. We went ahead and did clinical exome sequencing targeted towards the retinal dystrophy panel, which showed homozygous autosomal recessive inheritance with frame shift deletion of single nucleotide at exon 7 of CARKL gene in chromosome 2, which was again confirmed by Sanger validation. So we made a diagnosis of both eyes circle gene associated retinitis pigmentosa. We could get information on 3 more affected members in the family. This is case 2, mother of 10-year-old proband. She is a 39-year-old female who had a diminution of central vision from early childhood and later affection of night vision as well as peripheral vision from 2nd to 3rd decade. So the child has now again presented with the central vision problem similar to the mother. On examination, her BCVA in both eyes was just hand motion appreciation. Fundus of both eyes showed a subtle pallor of optic disc, prominent vascular attenuation, peripheral bony spicule-like pigmentation, peripheral scalloped chorioretinal atrophic patches, prominent diffuse granular RPE abnormalities in the background retina, and what is striking is central macular atrophy with pigmentation. The autofluorescence showed central macular total hypoautofluorescence and peripheral mixed hyper and hypoautofluorescence. The OCT of central macula in both eyes showed widespread affection of the photoreceptor layer with RPE and choroidal thinning as well. This is a 13-year-old boy. This is the case 3, who is the first cousin of 10-year-old child, presented with the complaint of prominent night vision problems as well as central vision. His BCVA at presentation was 20, 30 and N12. His fundus of both eyes showed, just like the proband which we just had in the previous slides, a minimal arterial attenuation, subtle optic disc pallor, and some central foveal abnormalities. There was again no pigmentary or chorioretinal atrophic changes in the retina, similar to the proband, that is 10-year-old boy. The autofluorescence showed a subtle hyperautofluorescent ring, but there was widespread affection of the photoreceptor layer in both eyes OCT. Full field ERG of the cousin again showed affection of cones as well as rods, and the genetic defect was found again in a circle gene, the frame shift deletion. We also had information on another affected member in the family, that is 42-year-old aunt of the proband. Her vision was very low, PLPR, hence we do not have documentation of the imaging, but on examination all her findings was similar to the 39-year-old female. So how is circle phenotype varying at different ages in this family? The top row shows the fundus of 10-year-old boy and 13-year-old boy. And then at the bottom, we have the 13-year-old female. The kids have a near normal fundus with just only attenuation and central vision affection, whereas the mother has severe widespread involvement in the retina with central macular atrophy as well. So if we can intervene somewhere at this juncture, maybe the child will not go blind as her mother. So phenotypical presentation at different ages seen over here are common to all is macular photoreceptor affection, severely affected full field ERG. In younger kids, we see that there is minimal to no disc pallor, minimal arterial attenuation, no typical RP pigmentary changes. In older female, we see a prominent peripheral scalloped chorioretinal atrophic patches with involvement of the macula as well. So how is circle phenotype different from what is there in our mind as typical RP? In majority of the RP phenotypes, they'll have mostly a night and peripheral vision problems to begin with late macular involvement and typical bony spicule-like pigmentary changes. Whereas in circle phenotype, there is always early central vision affection problem with central macular photoreceptor affection. It is mostly a paucipigmentary change, and there is scalloped chorioretinal atrophic patches in the late stage involving the macula. I would like to end my talk with these messages. Circle gene related RP shows a wide spectrum of phenotypical changes at different ages. Phenotypical features vary from early macular involvement and paucipigmentary changes in the first decade to severe macular atrophy and typical RP-like changes later. Knowledge on changing phenotype due to circle gene from early to later part of life helps in appropriate diagnosis, early visual rehabilitation, and career counseling. The present family highlights the crucial role of genetic counseling and testing for future generation risk assessment. Thank you for your attention. Thank you again.
Thank you, Dr. Deepika. Interesting lecture. Now, the second last topic of this session is on Stickler syndrome. Since Dr. Mona Bhende is unavailable, we have Dr. Sri Priya. She's a senior scientist in the genetic department of Shankar Nethralaya and has been associated with them since several years. She has many grants to her name. Over to you, Dr. Sri Priya from Shankar Nethralaya.
Dr. Sri Priya, good afternoon. Are you there?
Yeah, good afternoon. Am I
Dr. Sri
audible?
Priya, Dr. Natarajan here.
Am I audible, sir?
Yeah, you're
Yes,
audible.
yes.
Can you hear me?
Yeah, I'm able to hear you. Yeah.
Okay, so just 1 minute. We have got Dr. Colonel Sandeep here, and we have got he will introduce for you, welcoming you.
Thank you so much.
So
Thank you.
I just
Thank you.
want you to introduce.
Thank you so much, Dr. Saab. So delighted. Yeah. Thank you so much. I'm honored, and of course, Dr. Natarajan and everybody. Yes, along with me today, there's a very, yeah. So we have, today we have the Theravada sect, the head Buddhist monk from Assam. He is Gyanavardha Bhikshu from Upper Assam from district Tinsukia. He's here with us to bless us all today. So I would request him to please come.
Dr. Kirit Modi is a senior most ophthalmologist, only 85 years young. And Dr. Naina Podar, professor of ophthalmology. Please come for 2 minutes only and then come. And we have Dr. Naina Podar, professor of ophthalmology from Nair Medical College. Okay. Come here, no? No, Naina. And Dr. Shailaja from Shroff Charity, Delhi. And Ria. So, and bless us for a.
Bhavatu sabba mangalang rakantu sabba devada sabba buddha anubhavena sada sukhi bhavantu te. Bhavatu sabba mangalang rakantu sabba devada sabba dhamma anubhavena sada sukhi bhavantu te. Bhavatu sabba mangalang rakantu sabba devata sabba sangha anubhavena sada sukhi bhavantu te abhivadana silesa nisang buddha pasayino sataro dhamma vadanti आयु वन्नं सुखं वलांति। अच्छा लगा
Thank
आप
you.
लोग को आके सब डॉक्टर लोग को मिलके खुशी हुआ, अच्छा लगा सबको ब्लेसिंग।
हमारा होल कॉन्फ्रेंस है जेनेटिक्स का है, हमारा रिसर्च है। डॉक्टर जान प्रकाश अमेरिका से आया है एंड अभी शंकर नेत्रालय से डॉक्टर श्रीप्रिया बात करने का, सब डॉक्टर्स इधर है एंड पूरा दुनिया सुन रहा है एंड यूट्यूब में भी होएगा।
जापान से, हांगकांग से, चाइना से, अमेरिका से और टर्की से और भी बहुत सारे so many people are watching. Dr. Takeshi Iwata who is in वो टोक्यो में बैठे हुए हैं, जापान में वो हमारे प्रेसिडेंट हैं ग्लोबल आई जेनेटिक्स कंसोर्शियम के डॉक्टर टकेशी इवाटा, प्रोफेसर कैल्विन पैंग वो हांगकांग में बैठे हुए हैं, हमारे साइंटिफिक कमेटी के चेयरमैन हैं डॉक्टर आई सी डॉक्टर फुलिया, शी इज वो टर्की में है और भी बहुत सारे अमेरिका से भी बहुत सारे लोग हैं, बहुत सारे साइंटिस्ट प्रोफेसर,
मेक्सिको से डॉक्टर तानिया,
मेक्सिको से बहुत सारे देशों से लोग यहाँ पे इस समय ज्वाइन कर रहे हैं, बहुत सारे कंट्रीज से ये सब लोग।
हमारा मेन आइडिया है ये ब्लाइंडनेस को निकालने का, अंधापन निकालने का।
तो ये जेनेटिक्स की जो मीटिंग हो रही है उसमें यूनिक पॉपुलेशन की बहुत इंपॉर्टेंस है। यूनिक पॉपुलेशन जो आप रिप्रेजेंट करते हैं और जो आप नॉर्थ ईस्ट में आपका जो मॉनेस्ट्री है वहाँ पे लोग सैकड़ों सालों से वहाँ पे लोग काम करते आ रहे हैं और बहुत सारे आपके जो लोग पुराने पॉपुलेशन के लोग हैं जो कि अभी उन्होंने बहुत ज्यादा दुनिया से मिक्सिंग नहीं हुई है, तो उन लोगों का जो जीन्स है वो बहुत सारे हमारे साइंटिस्ट कहते हैं कि वो प्रिजर्व्ड है और उसमें ज्यादा मिक्सिंग नहीं हुआ है, तो हम लोग वहाँ पे उनके साथ काम कर सकते हैं आपके साथ। तो बहुत सारे चीजों के ब्लाइंडनेस के आंसर हमको मिल सकते हैं कि भाई वो लोग क्या खाते हैं, कैसे रहते हैं, उनका वातावरण कैसा है, तो उससे हम लोगों को बहुत सारी इम्पोर्टेंट इंफॉर्मेशन मिल सकती है। मेरी बात समझ रहे हैं? तो इसलिए आपका पार्टिसिपेशन, आपका यहाँ आना बहुत ही इम्पोर्टेंट है और उसके साथ में कर्नल सुनील कौशल जी को मैं बहुत बहुत धन्यवाद देना चाहता। कर्नल कौशल, संदीप कौशल is a new friend and a good friend actually. Colonel Sandeep is one of the smartest men I've met actually, and we had a pleasure of meeting him, and he joined us in Pune for various activities, and he's really played a key role in the politics, the people who are policy makers in this country, I should say. So Colonel Sandeep, thank you once again. You have delivered. You have delivered, Colonel, right? Yeah. So would you like to say something, Colonel?
Thank you so much. All the words of appreciation by our Dr. Gyan Prakash and of course, Dr. Natarajan, both are eminent personalities we all know today here. And I thank him from my heart, bottom of my heart. They're giving us an opportunity. Our Gyanvada Bhikkhu, the Theravada sect head from Northeast is here with us. And I'm so delighted that I could get this opportunity to bring him here amidst all of us and bless this conference and the initiative taken by both the eminent doctors. We wish all of them all the very best, and I'm sure in their mission they will succeed. Thank you so much, and eradicate the blindness from this planet. Thank you so much. Thanks, Itan.
Dr. Sripriya, sorry for the interruption. Takeshi, sorry for the interruption. Sripriya, you can start.
Yes, sir.
Thank you. Thank you, Dr. Fulia.
My screen is visible? Yeah.
Yes.
So here I am to discuss with you about our observation on a case series of retinal detachment, where we have done the genetic analysis. I am presenting on behalf of Dr. Munna Bande, a senior vitreous retina surgeon. So just the introduction I will skip. just to give a glance of what we see at our genetics department. So this slide represents the 5 years data from our department of those patients who have been referred for both genetic counseling and subsequently some of them, a percentage of them go ahead with the genetic testing. And we can see that majority are on inherited retinal degenerations, of its RP forms the major chunk. And then we also have genetic testing offered for other cases like Leber's hereditary optic neuropathy, where we concentrate on only the 3 primary mutations, and also for RB, and then for a few complex diseases.
Dr. Shripriya, please, can you make it slideshow?
Oh, okay. So the earlier slide describes about the 5 years data from our department on the various diseases that were referred for the genetic counseling and genetic testing. And most of them we advise them. We do the pre-test counseling, and then we discuss with them about the potential genetic nature of the disease after a detailed pedigree construction. And then if there is a minor, we always encourage the person to be accompanied by their parents, biological parents, and then we discuss with them about the possible genetic nature of the disease, and then we explain them about the genetic test, its implications and the cost, and also the limitations. And then with their informed consent, we go ahead with the genetic testing. And once with the result, we get back to them with the post-test counseling, either to telecounseling or a telephonic conversation, or in person when they come for their next visit. And then we explain them about the test results and then the further options. And along with us, we have the we have the clinicians also who take part in these, where they also discuss with the patient during the next visit in their clinic. And having said this, so this is how we do the pedigree charting. We have a systematic way of charting, and then we document all the details of the patients. And then I'm just skipping. So once we have the genotyping, either it can be a panel, or in case of certain diseases where we have 90% or more of the mutation in a single gene, like the retinoschisis, or the PAX6 gene for aniridia, we do the sequencing, and then accordingly the results are taken to the patients, and then further they are documented in their electronic medical record also. So coming to the topic of today, that is regmatogenous retinal detachment. So this is a disorder with an incidence of 1 per 10,000 individual, especially in whites. And here we have in India prevalence of 1.38 per 100,000 individual and reported. And however, there are not much of genetic reports on Stickler syndrome. And the reason, the disease, the etiology can be idiopathic or acquired or familial, or they can be either a isolated or a part of certain syndrome. So here in this slide, I have just given you about the various genes that are associated with Stickler syndrome and other vitreoretinopathies, which are a part of syndromes also, like the Marshall, Wegener, Knobloch, etc. So here in this particular series of cases, the patients were referred with the suspicion because they had a retinal detachment, and then the clinician wanted us to know the genetic cause and subsequently the classification or the molecular classification, which can help in their family member. So this is the flow chart of the work that we have done, following a detailed pedigree charting, and then we did the clinical exome sequencing in all the probands alone, because there are a panel of genes, and therefore at that time, so there was a clinical exome available. So we did, and then it was from the service providers, and then we had the results reported as per the ACMG guidelines. And following this, we went back to the patient, explained them, and since there were many members affected in these families, we gave them the option of analysis in the other family members, and then with their consent, we proceeded with that. So in this family, there was a strong history of retinal detachment, where you can find that in this generation, almost all of them were affected. And then except for members 3.1 and 3.6. And then we did identify a mutation in the COL2A1 gene. And interestingly, in this fourth generation, that is in this generation, the all these members who had the GA mutation, since they were of only 22 years age or 14 years age, they didn't show any symptoms of the retinal detachment, but however, it helped us in doing then predictive testing, that in that way they can go ahead with the further follow-up with the clinician and for the management of the disease. And this is the second case where we again found a mutation in a gene called as COL11A1 gene. So if you take Stickler syndrome, 10 to 15% of the cases do have mutations in the COL11A1 gene. And in this pedigree, the mutation was identified in the COL11A1 gene. And it is an autosomal dominant disease. And you can see that it is inherited from the affected father. The heterozygous mutation is affected to the next generation. And this is a fundus picture of the family members, the SIBs, both the SIBs in family 3, and where you can see that they share the retinal features, and that was actually treated by the clinician. And this is the family 3 where we identified mutation in the COL2A1 gene. And again, it is an recessive disorder. But they had, the father did not have the disease, but there was an history of vision problem reported in the maternal side, but however, they were not very clear. So we further advised them for the examination in the maternal side. And this is the clinical picture of the SIBs that you saw in the earlier pedigree. And in this family 4, we identified mutation in COL2A1 and COL11A1 gene. And interestingly, the COL11A1 gene, it was a variant of unknown significance, and the COL2A1 gene is a likely pathogenic. And here, we did the segregation analysis, but we identified that the father was normal for these, we didn't harbor the VUS that was reported, but the mother was harboring both the variants. However, further analysis correlation with the clinical features was more for Stickler 1 mediated by the COL2A1 and not by the COL11A1 because of the clinical features that we have listed here. Thus, in this family, the genetic diagnosis helped in the classification, molecular classification of the types of sticklers. So this is in a nutshell about the 4 variants that we have identified. And in one of the family, as I said, the variant of unknown significance that was identified was also screened in the control samples, like a cohort which did not have any ocular features, that was completely normal. And we were able to actually show that it was not there in this control sample, but it since the clinical correlation was more with the Stickler 1 type, we were able to subtype it as Stickler 1. And this was published in IJO journal in 2022. And following this, we had tested a case series of suspected retinal detachment, and then we were able to identify in almost 90% or out of 3 cases did not show any mutation in the known candidate genes, but the other samples we were able to make a diagnosis based on the genetic picture. So this does suggest that there are yet some more novel genes that or a detailed analysis of the other regions might help us in identifying the new genes. So thus, here the molecular screening has helped in supporting the clinical diagnosis of Stickler syndrome in these 4 families, and a diagnosis of, like for example, in this case, the patient with familial exudative retinopathy, we were able, the total retinal detachment, we were able to identify mutation in LRP5, which is more strongly towards a diagnosis of FEVR. So like that, our genetic testing has helped here. And also it has helped in predictive testing in the asymptomatic members, as you saw in the pedigree 1, where we were able to identify carriers or asymptomatic members with the mutation, GE mutation. Thus, they can have a follow-up, because in retinal detachment, an earlier identification always helps in the management of the disease and then the prevention of blindness in these cases. And the genetic testing results also help in confirming the molecular type here and the classification. And it also helped. So in these cases, however, we didn't identify any variants that were associated with other non-ocular non-ocular feature, except for the family 3, where we identified another variant of unknown significance in a gene called as PKP2 that is associated with it is an heart condition. But however, the father was asymptomatic for that, and therefore we were able to rule out that might not be the but even though we were able to rule out that it might not be the causator, but however we were able to advise them for further clinical follow-up for any putative management options. Thus, here I want to add on that even though we get the results as we were seeing early in the 2 days, so we were able to, even though we do get the genetic test report, we should be able to carefully segregate and then interpret the results before taking it to the patient for any conclusive action. So here, whenever we identify an VUS, we generally explain them with the potential limitation, and then we give them the option of co-segregation analysis and emphasize that for any further decision making, this is important. And since we also have a cohort of sample without any ocular feature, it is also helping us to screening out in these normal individuals the status of this VUS and then taking it back to the patient. Thank you.
Thank you, Dr. Sripriya. That was actually a very good talk, and you were so interventional with these families with sticklers and went the extra mile with them, and hopefully that will help us understand the disease even better, how within the same family things are different between different individuals and what all steps we can take. So that was amazing. Thank you so much. Now is the last talk of this session from Dr. Leah Kovac. She's an ophthalmology specialist at University Clinical Center, Ljubljana, and her interests lie in neuro-ophthalmology, ophthalmic genetics, ophthalmic ecography, and contact lens fitting. Okay, we can.
Hello, everyone. My name is Leah Kovac. I'm an ophthalmologist at the University Medical Center in Ljubljana, where I work with a team of neuro-ophthalmologists and experts in hereditary ophthalmic diseases. I would like to thank the organizers for giving me the opportunity to present at the symposium and to share with you a case of bilateral visual loss in a patient with cystic fibrosis. A 28-year-old male presented to a clinic with gradual worsening of visual acuity in both eyes, hearing worsening, and paresthesias. His personal history was relevant for a recent exacerbation of cystic fibrosis in a terminal stage. He had been on a prolonged course of several antibiotics due to a secondary chronic pulmonary infection for at least a year, among other supportive therapy. On examination, we found symmetrically diminished visual acuity that was progressively worsening, diminished color vision, and central visual field defects. In both fundi, we could see hyperemic, swollen optic discs, and tortuous vessels, with retinal nerve fiber layer thickening and ganglion cell layer thinning on OCT. Fluorescent angiography showed no dye leakage on the optic disc, which would normally be expected in an optic disc edema of inflammatory or ischemic etiology. Having excluded other causes of bilateral optic neuropathy, Our primary differential diagnosis was Leber's hereditary optic neuropathy, or LON. LON is the most common inherited optic neuropathy, caused by mutations in the mitochondrial DNA. The most typical 3 mutations are listed on the top of the slide. These mutations primarily affect mitochondrial respiratory chain complex 1 genes. LON typically affects young males, and as shown here, clinical findings in LON correspond almost entirely to what we've seen in our patient as well. So we ordered genetic testing for hereditary optic neuropathies. The results did not reveal any typical LON mutations. However, a novel variant of OPA3 gene was found that was classified as a variation of unknown significance. Segregation analysis was advised, but we're still waiting for the results. OPA genes also encode mitochondrial structural proteins. Known OPA3 gene mutations have actually been reported to cause conditions involving dominant optic atrophy, but that typically has an insidious course and starts earlier in life. So this result did not entirely explain findings in our patient. So we looked further if there could be a connection between the optic neuropathy and the exacerbation of his primary genetic disease, cystic fibrosis. As we know, cystic fibrosis is a genetic autosomal recessive pulmonary disease that is due to mutations in CFTR gene, which are traditionally known to cause a dysfunction of a transmembrane chloride channel. Recent research, however, suggests that reduced CFTR activity actually downregulates mitochondrial ND4 gene expression, which is also one of the genes affected in LON, and thus influencing complex 1 activity. Additionally, early cases of similar optic neuropathies were reported in the 50s, which was attributed to toxicity of prolonged chloramphenicol treatment in children with cystic fibrosis. Later, it was found that some antibiotics can cause disruption in mitochondrial function. This effect was most commonly reported with the use of linezolid, which was also used in our patient, and described with similar clinical presentation as acute LON. In our patient, there was actually a combination of several factors that could contribute to the diminished mitochondrial activity, all leading to a bilateral neuropathy resembling acute LON. We addressed manageable factors. Antibiotic treatment was discontinued. He received supportive therapy in the form of supplemental vitamins and coenzyme Q10. And as he was previously scheduled, he underwent a lung transplant, which obviously also improved his respiratory function. On follow-up examination, after 5 months, his visual acuity and color vision both had returned completely to normal, and his visual field improved significantly. The patient reported that his visual acuity started to improve already within the first month of discontinuing the antibiotics. However, he was not able to attend previously scheduled appointments due to undergoing lung transplant surgery. Fundus appearance returned to normal as well, though a moderate ganglion cell loss on macular OCT was still observed. In conclusion, I would like to highlight that patients with cystic fibrosis might actually feature a mitochondrial disease and therefore could be at a higher risk for a mitochondrial optic neuropathy. Variants of OPA3 gene might be an additive factor to cause clinical features of acute LON. And also antibiotics should be considered as possible environmental triggers for disruption in mitochondrial metabolism, especially in genetically susceptible individuals. Thank you very much for your attention. Unfortunately, I will not be able to join the online discussion, but if there might be any questions occurring, I would happily answer them on this email address. So thank you again and enjoy the symposium and lectures.
Hello. Yeah. So yeah, I can. So thank you all for your kind attention. I think we really short the time, but we had good discussions in between. So the next section will actually begin at 2. And meanwhile, people can have lunch and come back. So others are already having lunch. So we can start the next session at 2.
Dr. Shelja to give moment to Dr. Ria. Okay. I request Dr. Naina Poddar ma'am to give moment to Dr. Ria. I request Dr. Shelja to give moment to Dr. Naina.
It was wonderful and nice.
Thank you, ma'am.